Hello everyone, and welcome to this online session entitled PID and the Lung. I am co-hosting this session with John Hurst, who was so kind to let me do the introduction. Of course, we all know that from all organs and tissues in the human body, the lung is one of the organs that is most often affected in PID. We know that lung disease can be debilitating and that end-stage lung disease can lead to reduced life expectancy in PID patients. So, we should have every incentive to diagnose and treat PID-related lung disease, and better yet, to prevent it. Now, in this session, we will have three very interesting presentations on PID affecting the lungs. We are pleased that we will hear both basic research from Dr. Tracy Hussell from Manchester University and a clinical story by Klaus Warnatz from Freiburg, and a presentation on lung fibrosis and telomere disorders by Sharon Savage from the National Cancer Institute. A short word on collaborative efforts. Since lung disease and PID is very rare, it has been shown that international collaborative efforts are probably needed here in this field. So we encourage you all to learn more about the eGLILT consortium and other collaborative initiatives, as we think that part of the breakthroughs in this field will come from the larger consortium efforts. We look really forward to a very interesting session, and I suggest we will go and start with the first talk.
Hello, I've been asked to provide a talk on lung immunology, so I thought I would first highlight the unique features of immunity at this site before moving on to the more recent discoveries that we have made. As you may know, the lung is part of the mucosal-associated lymphoid tissue system that essentially incorporates any site with an epithelial barrier. So that includes the eye, the nasal cavity, gut, breast, urogenital tract. All of these sites are exposed one way or another to the external environment. This is particularly relevant at the moment with the current COVID-19 pandemic. Your mucosal tissues are exposed to various things in droplets, virus, bacteria, but also environmental antigens. So the immune system in this site really has to be adaptive to the environment that it's encountering. The last thing you want in your lungs is a massive inflammatory response, such as we're seeing in the SARS-CoV-2 infection. Therefore, there are numerous barrier strategies to eliminate pathogens that do not actually involve your immune system. And those include histological architecture of the mucosa, so the junctions between the epithelial cells are very tight. There's rapid turnover of the epithelium that are replenished from stem cells. And there's the presence of mucus and the glycocalyx that actually agglutinate antigens. These are very anti-inflammatory mechanisms. So a pathogen first would have to breach these particular defenses. We've also got cilia that capture that mucus and waft it up into the upper airways, which you then exasperate and then swallow. We've also got the presence of an abundant microflora, the sort of friendly bacteria that actually compete for nutrients and attachment sites at this site. Now, if you look at your mucosal immune system, and this is quite common across sites, it's a complicated slide, but what it's trying to show is that it varies depending on how low down you go. In the larger airways, you have ciliated epithelial cells and secretory cells containing antimicrobial peptides. The mucus that's secreted by these secretory cells traps antigens and then sort of wafts it up for expulsion. In the interstitial spaces, there's a sort of smattering of immune cells, but mostly they belong to part of your innate immune system. So we've got gamma delta T cells, we've got NK T cells, we've got innate lymphoid cells, and these mucosal associated invariant cells. These are present at low numbers in the respiratory tract, and they respond extremely rapidly to any antigens at that site. However, if you look at the very smallest air spaces, the alveoli, this is where gaseous exchange has to occur. This is the day job. And so here there are very few cells, except my favorite one, which is the airway or alveolar macrophage. Now, epithelial cells themselves, once thought of as simply a barrier, are now known to sense and respond to a variety of different factors, which it does in health over this side, but it also does it in disease when there's some sort of damage or an infectious particle there. Your epithelium can actually tell the difference between a harmless commensal and a pathogenic microorganism. So it can provide sort of strategies to keep antigens out, but it can also inflame if there is a problem in the air spaces. The epithelium is more involved in the immune response than was originally thought. So, for example, pathogens can bind to various receptors shown here on the surface of epithelial cells. There are also extracellular and intracellular innate recognition receptors, so the toll-like receptors, the nod-like receptors, the rig-eye-like receptors. So these pathogens can bind to your epithelium, and then that can be sensed through all of these pattern recognition receptors. And that will lead to the generation of pro-inflammatory innate and adaptive immune responses and the production of type 1 interferon. So the epithelium really is the gatekeeper that recognizes and starts an inflammatory response. These events typically lead to the clearance of pathogens in healthy individuals, but in patients with chronic respiratory diseases such as asthma and COPD, these defenses can be impaired, leading to increased susceptibility to infection. So the epithelium plays a critical role in immunity in health and disease. Another clearance mechanism at most mucosal sites is IgA, and IgA exists in a dimeric form, two joined together by this J chain that enables it to bind to this poly-Ig receptor. And what this interaction does is it causes endocytosis. The dimeric IgA is then transported across the epithelial cell and liberated into the lung lumen, just as it is in the gastric lumen. Now, a little bit of this J chain and this whole complex here is actually maintained when it gets secreted out into the lumen. It's called secretory IgA, and it basically protects it against proteolytic digestion. Now, what dimeric IgA does, it forms this agglutination strategy where when it's chucked out into the lumen, it can actually agglutinate antigens, making them much bigger and preventing them from sort of simply diffusing through the epithelial cell. And the benefit of IgA in the mucosal tissues is it doesn't fix complement very well. So this is quite an anti-inflammatory way of actually getting rid of antigens and parasites in your lower respiratory tract. B cells, let's talk about B cells. Though the lung contains only sparse immune cells, as shown here, lymphoid-like structures can be induced when they are required, so they're sort of inducible. Infections cause the formation of bronchus-associated lymphoid tissue de novo, so undefined mediators, possibly originating from the epithelium, act on resident lung cells such as macrophages, dendritic cells, lymphocytes, and structural cells to coordinate this bronchus-associated lymphoid tissue formation. And this functions to sustain adaptive immune responses against subsequent infections. But obviously, these this lymphoid tissue is sparse, otherwise gaseous exchange would be impaired. Now, airway macrophages deserve special attention because they are my favorite cell and they perform many functions within the lung that often require very different functions. And I have called this a collision of functions, because although they have to induce inflammation to pathogens, they also have to inhibit inflammation when they're clearing your own dead and dying cells and the products of extracellular matrix turnover. So this single macrophage that you see here has to either inflame or it has to inhibit inflammation, depending on the role that it's performing at the time. And so how does it do that? Well, it does that. The activity is determined by the balance of activating and inhibitory signals. So rather like this dimmer switch for a light, macrophage activity can be promoted by signaling through the toll-like receptors I mentioned earlier, CD40, late co-stimulators such as OX40 ligand and CD40. On the other hand, they can be inhibited by immune suppressive cytokines such as interleukin 10 and receptors such as CD200 receptor. So their activity really depends on what they're interacting with and what function they need to perform. If they need to respond to a pathogen, these pathways are more beneficial that activate or brighten their activity. Whereas if you're clearing extracellular matrix proteins or your own cells, then you need to dampen the immune response. So it's all about balance. And this balance is site-specific. Now, in health, we and others have shown that the epithelium plays a significant role in suppressing the inflammatory activity of airway macrophages in health. So these cells aren't just sitting there waiting for an antigen to come along. They are being instructed that there's no antigen there by signals from the epithelium. And these signals include the production of interleukin 10, which turns off inflammation, the interaction of CD200 from the epithelium with its receptor on macrophages that shuts off a variety of signaling cascades, TGF-beta, which is immune suppressive, and the surfactants produced by those secretory epithelial cells bind to receptors on macrophage cell surface to limit their activity. So, for example, surfactant proteins A and D bind SIRF alpha that ultimately inhibit phagocytosis. So in health, you are instructed not to respond. The threshold at which a macrophage activation occurs is really important. So if you've got all these negative regulatory processes in place, then you won't respond. However, if you've set your tolerance level too low, such as what happens in an allergic situation, you start responding to things that you really shouldn't respond to, like allergens, house dust mite, grass pollen, etc. And so people who tend to be a bit more sensitive to environmental antigens may have their tolerance level set too low. And by tolerance level, I mean the regulation of airway macrophages by the epithelium. On the other hand, if you set your tolerance level a little bit too high, then you might ignore a real threat for so long that when you do finally respond to it, your immune system has more to deal with and goes overboard. So this is the excessive inflammation that has been described in post-mortem specimens from COVID-19 patients. You can see lots of infiltrating immune cells, most of which are lymphocytes in these dark purple spots here. You can see hyaline matrix formation shown by this arrowhead here. So not only can you end up with an excessive inflammatory response, but your macrophages may turn into a wound healing phenotype that is not very good at getting rid of pathogens, but is more associated with the repair process. Now, what dictates whether you optimally react to antigens or if you overreact or underreact? We and others have shown that often the level at which airway macrophages are activated is different following the clearance of a severe inflammatory infection. So you may be regulated optimally in health, you generate an inflammatory response, and then when all of that goes away, you don't quite go back to where you were. So we have shown upregulation of receptors recognizing apoptotic cells. We've shown upregulation of receptors recognizing extracellular matrix. We've seen microRNA shifts, etc., etc. The tolerance of this macrophage is very different to what it was at the beginning. And what we're interested in is why that is the case. Now, the clearance of apoptotic cells is important. If you don't clear them, they undergo secondary necrosis, which is a highly inflammatory event. This process is called efferocytosis. However, if you've got ongoing efferocytosis, then the whole system is turned off. So what I mean is that when the cell undergoes apoptosis, it externalizes phosphatidylserine on the cell surface, and this is recognized by a lot of phosphatidylserine recognizing receptors. And the ones that we've worked on are the TAM receptors, and TAM stands for tyro, axle, and mer, that recognize phosphatidylserine on the surface of the apoptotic cell via this bridging molecule that's called protein S or Gas6. So this is a way that phagocytic cells recognize that they're interacting with an apoptotic cell. Now, you don't want to respond in an inflammatory way to that apoptotic cell, otherwise you'll end up with autoimmunity. And so the system is set up so that if you have recognition of apoptotic cells in the presence of certain cytokines like type 1 interferons, then you phosphorylate STAT1, which leads to the upregulation of SOX1 and SOX3. And this blocks a multitude of signaling cascades from toll-like receptors to cytokine receptor signaling. So just binding of the macrophage's axle receptor, recognizing apoptotic cells via Gas6 will turn off inflammation, which is good to stop autoimmunity, but it could be bad if you're then trying to clear something else that comes along later. Another thing that affects the inflammatory tone of airway macrophages is the clearance of extracellular matrix. Again, this is your own protein, so you don't want to inflame to it. Following resolution of a highly inflammatory influenza infection, but we see, if we look at mass spectrometry, that basement membrane is reduced, but extracellular matrix remains high, and it remains high for significant periods of time. Now, basement membrane loss is not very good because the lungs end up very leaky, but equally, if you have higher levels of extracellular matrix, then the lungs would become stiffer, and you will impede gaseous exchange. So there are receptors that actually recognize this extracellular matrix and try and clear it, one of which is CD44, which binds to hyaluronan. We have asked what happens to matrix in the lung. Hyaluronan is extruded from cells by various synthases. We've found that following a severe influenza infection, it's not the clearance that's the problem of extracellular matrix, because we instilled some biotinylated HA and showed that that was equally cleared in naive mice at the peak of their inflammatory response, and in those that had resolved infection. So it's not clearance. It's not really the hyaluronidases which break down matrix. They're all the same, all three hyaluronidases. But what we found is that the synthases are maintained at a high level. So it seems that following an influenza infection, some things return to normal, some things don't. And one thing that doesn't is this HA synthase 2, which extrudes hyaluronan from the surface of cells that are producing it. And this likely explains why the lungs are maintaining this at a higher level and why they're a little bit stiffer. Now, interestingly, this has therapeutic implications, because here we've induced that problem in a mouse model and found that if we actually administer some hyaluronidase that will digest the HA, we can restore the lung function of mice completely back to normal. So the presence of extracellular matrix is something that could be therapeutically targeted. So finally, I wanted to mention in my summary, it's all about restoring the system back to its original state. So our lung starts with an appropriate elasticity for optimal gaseous exchange, but the manner in which it's restored can leave some with a lung that is stiffer. So we end up sort of almost up here where we have stromal tissue, and this is not very good for respiration or exchange of oxygen and carbon dioxide. But more importantly, it's not just a stiffer tissue. There are immune cells contained within that tissue. And equally, and relevant to this conference, is that some people may be born with alterations that change the reactivity of lung immune cells from the beginning. So it's all about restoration, and it's all about the interaction of your immune cells with the sort of structural cells within the tissue. That just leaves me to thank all the lab members. There are a lot of previous lab members I've left off who've contributed to these hypotheses. Very grateful to my clinical collaborators, the Wellcome Trust, GSK, MRC, and I'm part of the United Kingdom Coronavirus Immune Consortium. Thank you very much.
My name is Klaus Warnatz. I'm the head of the Division of Immunodeficiency at the CCI in Freiburg, Germany. And I was asked to present our thoughts on interstitial lung disease in primary immunodeficiency, diagnosis and management. There will be questions, and we will be able to answer them if you submit them online after this session. These are my disclosures. The grant by Bristol Myers Squibb allowed us to perform the SAIL study where we tested the safety and efficacy of abatacept in interstitial lung disease, and I will refer to it later. The aims of my talk are to understand pathomechanisms underlying the interstitial lung disease in CVID, to help diagnose CVID in interstitial lung disease, and to manage the interstitial lung disease in cooperation with the pulmonologist. Let's start with the case report. We had a 24-year-old male patient who presented with exercise-induced dyspnea. You can see the CT scan on the right-hand side. In his previous history, at 17 years, he had the first bout of an autoimmune hemolytic anemia. At 23 years, he presented with recurrent sinusitis, which was not attended. And 1 year later, he recognized the dyspnea I just mentioned and dry cough, which was existing now for 2 months. The CT scan not only revealed the changes you can see up there with nodules as well as ground glass opacities, but also a splenomegaly and lymphadenopathy. The diagnostic workup was remarkable for mild thrombocytopenia. The LDH was slightly elevated, the CRP levels as well, and the soluble IL-2 receptor was elevated to 2,400 units per milliliter. We performed, as the next step, after having the CT scan and the clinical history, bronchoalveolar lavage, which revealed the lymphocytic infiltration with an increased CD4-CD8 ratio. There were no pathogens identified, and in the serum was remarkable that there was a reduction of IgG to 3.2. IgA was not detectable, and IgM was decreased as well. So the diagnosis was made at that time of a common variable immunodeficiency with an involvement of the lungs in the interstitial lung disease. I think it is important to mention that there are two ways lungs can be involved in the common variable immunodeficiency. There's airway disease, which is present in at least 30% of the patients with bronchiectasis. It is thought to be infectious driven. It is usually local, but can be generalized in the lung, and it is involving the innate immune system. On the other hand, there's interstitial lung disease, as you can see on the right-hand side. About 15 to 20% of the patients are affected by this. It is thought to be immune-mediated. It is thought to be part of the systemic immune dysregulation, and the main players at this time are thought to be part of the adaptive immune system. Let me start with the pathology. As I mentioned, interstitial lung disease and CVID is part of a systemic immune disorder. We can see infiltrates through either T and B cells, and they're usually mixed. And you see here the CD20 staining from a publication from Paul Maglione, where you can see nice follicles, and they build even tertiary germinal centers in this, but you can see adjacent the T cell zones. You can see the classical marker for germinal centers with BCL6, the proliferative activity of this, and what Paul Maglione showed very nicely in the last year's publication is that there's increased IgM production locally, as well as BUF being as the B cell factor, growth factor being involved in the pathogenesis. The histology, in addition to the lymphocytic infiltration, often shows granuloma, but not necessarily so, as well as inflammatory lesions, for example, in organizing pneumonia. We went out and wanted to know what can we actually detect in the bronchial alveolar lavage of these patients. And you can see here an analysis which is just submitted for publication, where we analyzed T cells as well as B cells in the bronchial alveolar lavage. There's elevated T cells in the bronchial alveolar lavage of CVID patients. And you can see that in comparison to sarcoidosis patients, there's a higher percentage of follicular helper cells among these T cells. And when you do the separation in regards to the different cytokines being produced by these follicular helper cells, you can see an enrichment of TFH1 and a reduction of TFH17 cells in the bronchoalveolar lavage. At the same time, you see a strong reduction of regulatory T cells in the lavage, and this is associated with a chemokine called IP10, which is strongly associated with the TFH1 expansion by attracting CXCR3 positive T cells into the site. On the B cell side, we could see, first of all, that there are B cells, and significantly more than in sarcoidosis in the bronchoalveolar space. And when you analyze these cells, that most of them are TBET high CD21 low B cells. And this is significantly more so than in sarcoidosis. In addition to the BUF, which was reported by Paul Maglione, and which we could not detect very easily in the bronchoalveolar lavage of our patients, we saw an increase in APRIL, another growth factor important for B cell survival as well as differentiation. In summary, T and B cell expansion is present in the majority of patients, important for potential targets. The expansion of T cells includes mainly T follicular helper cells and especially TFH1 cells. There's a reduction of regulatory T cells at the site and an expansion of TBET high CD21 positive B cells. This reflects the general dysregulation we can see also in the periphery of these patients. Now, how do we diagnose CVID-ILD? There will be clinical signs. We need CT scan, lung function examinations, bronchoalveolar lavage, biopsy, and serum parameters, which are helpful in the diagnosis. Let me start with the clinic. The clinic, as in our patient, usually is in the beginning very small, very little symptoms. During the course of the disease and the progression, it will start usually with exercise-induced dyspnea and dry cough. Other hints, which are often present in the very beginning, are the splenomegaly in 70% of the patients, but there is also an increased autoimmune cytopenia present in these patients, as well as lymphadenopathy, while enteropathy doesn't seem to be enriched compared to the general CVID cohort. In conclusion, ILD is a part of the systemic disorder, which includes especially lymphoproliferative processes. CT scan will be the next step. Actually, it encompasses different morphologies. You will see nodules often subpleural, as I've shown in the previous picture. They're usually larger than in sarcoidosis and without the sharp edge. They often are by radiologists referred to like potential fungal infections. There's ground glass opacity and there are inflammatory lesions. In a few patients, and especially the ones which are progressing, you will see also reticular patterns compatible with fibrosis, sometimes resembling non-specific interstitial pneumonitis. And there's often, in our case, actually in over 80% of our still PET patients, we could detect concomitant bronchiectasis in these patients. This needs to be complemented by lung function tests. And in our retrospective part of the still PET study, we could see that there are CT changes in some patients without any symptoms and no abnormalities in the lung function. However, the majority already has a reduction in the CO diffusion, while some patients have been already progressed to even reduced forced vital capacity. Over the course of time, people will especially lose their CO diffusion, which you can see in this slide, while the forced vital capacities remains within the range of plus minus 10% of normal over a long time. Therefore, it is important to include CO diffusion in these patients. In the bronchoalveolar lavage, here you can see our data. As I've mentioned beforehand, we recommend to perform it as a less invasive procedure to detect lymphocytic infiltration and also already detect the increase of B cells as a potential treatment target in this patient population. We need the bronchoalveolar lavage to exclude pathogens, including fungi, to exclude lymphoma, even so this is probably not sufficient, but also to perform immunological assays with the typical outcome mentioned. In some patients, we find increased neutrophils. In many of them, this is associated with infection. However, this needs to be considered as it can be also a sign of a fibrotic progression of this disease. And the role of this within the diagnosis of interstitial lung disease needs to be determined in future studies. Biopsy is recommended by many, and biopsy can be performed in 3 different ways, either as transbronchial biopsies, as so-called cryobiopsies, or as video-assisted thoracoscopy. Here you can see the typical changes as I outlined beforehand. And in general, we do perform cryobiopsy whenever possible. We do not want to perform the video-assisted thoracoscopy because it is much more invasive. And as I show here in our study, in 25 of our cryobiopsies, we could find relevant findings telling us the morphology and of the histological background of this disease. It is important to do this, especially in CT scans, which are compatible with lymphoma, and the immune histology will reveal further details which are helpful for the understanding of this disease. However, in the publication of Manina et al., they could not find any significant difference in biopsy-proven and non-biopsy-proven, which are just based on CT scan changes, patients in the follow-up, as well as in the outcome. Serum parameters are rare because they are not specific for lung disease. However, one of the parameters which is helpful in this context are soluble IL-2 receptor in our hands, where we could demonstrate that all of our patients with interstitial lung disease had elevated levels of soluble IL-2 receptor, and we can potentially use it as a follow-up. By Paul Maglione, it has been suggested also the change of IgM rather than the increased IgM itself might be a parameter of active disease. For the management, a consensus conference has been pulled together by the British Lung Foundation and UK PID work under the lead of John Hurst. There was a strong consensus, as you can see, for patients who are symptomatic, have abnormal lung functions and deteriorating CT scan changes. So these patients should be treated. There was also the same strength of consensus on patients who did not show symptoms, but had abnormal lung function and deteriorating CT scans. There was already slightly less consensus in patients who are symptomatic, normal lung function, but deteriorating CT scans, and there was no consensus on any of the others mentioned below. Although I am convinced that we need to treat also patients with symptomatic patients with abnormal lung functions, and even if the CT scan changes, might be stable. And so therefore, then further research needs to be performed on this. While I think there was also strong consensus that patients who are asymptomatic have a normal lung function and a stable CT scan change compatible with ILD, don't need to be treated, but need to be followed up closely. Now, the big questions in regard to management is the role of steroid therapy, as it became clear from the recent survey we performed. And the other questions is, what are the other potential drugs if we can't use steroids alone? And to start with the steroids, we usually use steroids at the initiation of therapy, classically for adults at 1 milligram per kilogram body weight. And as you can see here, the changes, if you put patients newly onto steroid therapy, you can see that this leads to improvement in the majority of these patients, while very few patients will deteriorate under the initiation of steroid therapy. This is true for the CO diffusion. We see much less changes, as I reported previously, for the forced vital capacity. However, when we look at how patients perform under long-term steroid therapy, and this is usually maintenance dose of 5 or 7.5 milligrams a day, here we see a mixed picture where quite a few number of patients actually deteriorate under this treatment, and therefore steroid treatment is not sufficient to control the disease, and other forms of immunosuppression need to be thought of and implemented in these patients. Long-term high-dose steroid therapy is no alternative treatment for these patients. However, when we look at the literature, and this is a systematic review put together by Lammers and Smits and just submitted to Frontiers Immunology, we can see there's a large variety of different drugs being used, and there's no clear conclusion possible based on the current topic. I think the most evidence and the nicest work has been done by the group of Jack Roots, where he has tested the combination therapy of rituximab and azathioprine, and more recently in the combination with mycophenolate, where he tried to address the mixed TB infiltrate in the lungs. And he could show that both combinations actually are quite successful in treating this disease. However, there's also evidence that rituximab alone may be sufficient to control the disease if you take out the one player. And then there are less reports on other drugs, including mycophenolate alone, sirolimus, and most recently, and just in revision, is our sales study where we have tested abatacept in 10 cases with CVID. As a short summary of this, we have seen success in several of these patients. Overall, it seems to be a safe treatment. However, it doesn't seem to be as successful as it has been reported for patients with LRBA deficiency or in CTLA-4 deficiency. Now, to summarize our management thoughts, all patients should be managed in collaboration with experienced immunologists and pulmonologists. Not all patients with CVID-ILD require treatments. Patients should be at the time of immunosuppression on immunoglobulin replacement therapy. If treatment is required, infections needs to be excluded by bronchoalveolar lavage. The initiation with steroids is successful in most patients. Long-term treatment, however, requires the switch to other immunosuppressive therapies in patients with progressive disease. For the follow-up, we recommend close follow-up with every visit in regard to clinical complaints. CT scans we usually perform in patients with proven interstitial lung disease every 2 to 3 years by low-dose CT. MRI may represent an alternative, in this case, in centers where this is available. Lung function tests, including CO diffusion, are important and should be performed at least annually. Bronchoalveolar lavage and biopsy will be only performed if there are changes in the clinic or CT scans make you think of a different morphology and different underlying disease, especially lymphoma. And serum parameters still need to be determined, but in our hands, soluble IL-2 receptor and IgM might be helpful in detecting active disease. We're trying to answer this in a network called EGLIDNet, which was co-founded together with John Hurst under the sponsorship of the European Respiratory Society in collaboration with ESID. Please contact us if you have further questions on this. And please listen to Annick van de Veen tonight at 1822, where she will present the survey of this network in regard to what are the most burning questions in GLILD. So what are the take-home messages? Interstitial lung disease can be the first manifestation and is often thought to be sarcoidosis. And so it is important to make the distinction between the different diseases. It can be part, or it is part of the systemic immune dysregulation in CVIDs, often associated with additional manifestations like splenomegaly, lymphadenopathy, and autoimmunity. The diagnostics require chest CT, pulmonary function tests, including CO diffusion, bronchoalveolar lavage, and definitely in many patients, biopsy if possible. Treatment indication needs to be refined for each patient, including these parameters. Initiation can be done with steroids, usually with 1 milligram per kilogram body weight, and this is effective during the initiation. However, not as a maintenance, and there's no indication for long-term high-dose steroid therapy, as I said before. The optimal steroid-sparing therapy still needs to be defined, but rituximab with or without MMF seems to be promising in this regard. And with this, I come to my end. I need to acknowledge my clinical team, especially Sigrune Goldagger, who led the STILPAD study, my research team, and here especially Susanne Unger and David Friedman, who performed many of the research in the bronchoalveolar lavage of our patients, and Caroline von Spee-Meyer, who performed the SAIL study. The BAL research was complemented by Antje Passe in Hanover and Jonas Schupp, who's currently at Yale University. And especially I want to thank John Hurst, who's a fantastic collaborator and who was enabled me to be participating in the EGLIDNet. And here you see the current consortium leading this effort. With this, I'd like to close and thank you for your attention. And as I said, we will be happy to answer your online questions later during the session.
Hello, I'm very happy to be here today to tell you about our work in telomere biology disorders. And for this talk specifically, I'm going to focus a bit more on pulmonary disease, but really talk about the broad spectrum of phenotypes that we're seeing in our patients. I have no disclosures. So our multidisciplinary approach really incorporates clinical studies, basic science, and epidemiology principles, all in order to study rare, complex cancer predisposition syndromes and other disorders. And really, our approach to doing this is because we really want to ask the question, what's part of having an inherited disorder versus what's just part of being a member of that family? And so at the National Cancer Institute at the NIH in Bethesda, Maryland, we have a longitudinal cohort study approach where all of our participants start by calling the referral nurse and having review by the study team. We work with the epidemiologists, so we collect lots of questionnaire data. All of those participants become part of our field cohort where we have medical record review, genetic counseling, and testing. We can do biospecimen collections as well. And then a subset of those participants come to the NIH Clinical Center for detailed evaluation by our marrow failure team and by other subspecialists. The Inherited Bone Marrow Failure Syndrome study was opened in 2000 by Dr. Blanche Alter and really led by Drs. Alter and Dr. Geary, with myself working on dyskeratosis congenita and telomere biology disorders. predominantly. And our goals overall of this study are to identify the genetic causes of bone marrow failure syndromes, to understand the long-term medical complications of these disorders, build on the basic biology understanding, and also really focus on a collaborative resource where we have collaborators from all around the world, and we're always looking and open to new ideas and new collaborations. So I work on telomere biology disorders, and dyskeratosis congenita is the prototype. So just a brief overview, telomeres are long nucleotide repeats and a protein structure that cap chromosome ends. They're essential for chromosomal stability, but they shorten with each cell division, and that's because of the inability of the DNA replication machinery to replicate the 3' overhangs. When telomeres get to a critically short length, the cells are triggered to either undergo senescence or to undergo apoptosis. So I'm going to tell you a little bit about how we got here to understanding the etiology and complications of telomere biology disorders, but just wanted to show you kind of where I think of telomeres and human disease now after working on this for quite some time, in that there's a wide body of literature of rare, highly penetrant, complex disorders that are caused by very, very rare germline mutations and very, very short telomeres. There are some interesting disorders, including familial melanoma and others, that are associated with long telomeres and rare mutations. And then there are general population studies with looking at common variants and telomere lengths in the normal range, but shorter than average. I'm going to focus now, though, on the telomere biology disorders. And this all really came about because of these classic families like this one that were first described well over 100 years ago now, where you have a clear X-linked inheritance pattern, and the phenotypic features were these dysplastic fingernails and toenails, lacy reticular pigmentation of the upper neck and chest, although it does occur everywhere, and oral leukoplakia, these white spots in the mouth. And then as these patients were being studied, it was clear that they also developed severe bone marrow failure that at the time was often fatal, and there were some developmental delays, pulmonary fibrosis, and other complications. So initially it was thought to be X-linked, but then in the 60s, the first report of a female and review of the literature came out, and we now know that males and females are almost equally affected, except for the one X-linked gene, which changes the percentages just a bit. But we also have all modes of inheritance. And this also, so getting back to kind of where we all started with this. So in 1999 and 1999, Indrajit Dhokal's group and Kathy Collins' group found that there were germline mutations in dyscarin, which were in the X-linked form of DC, that was associated with very short telomeres and low levels of telomerase. And this really opened the field to thinking that telomere biology is associated with human disease. In 2007, and then a follow-up 5 years later, Blanche Alter and our group showed that if you looked at telomere length by flow fish of lymphocyte subsets, this is a graph of total lymphocytes, we also divided into subsets, we showed that patients with DC, shown in the colored symbols here, had telomere lengths less than the first percentile for their age. And when you compared them with their unaffected relatives and with patients with other marrow failure syndromes. And our follow-up studies showed that this was more than 95% sensitive and specific for dyskeratosis congenita. And then as time went on, we've had additional genes discovered. So in the first genes was the dyscarin gene, and then TERT and TERK came along as autosomal dominant disorders. And those came about just at the same time we were doing the telomere length studies, that we also were able to use those telomere length studies to discover TNF2 as a cause of autosomal dominant DC. And then you can see the number of genes has grown, and there's at least 14 different genes with autosomal dominant, autosomal recessive, and then the one X-linked recessive gene. The other additional part of this complex story is that you can have patients with, say, RTL1 or TERT mutations who are heterozygous and have adult onset disease. And then there are also biallelic patients who present much earlier in childhood. So you can have the same gene and have autosomal recessive or dominant disorder. So as a way to illustrate the clinical complexities of telomere biology disorders, I'm going to show you a case of this little boy who I first met when he was about 4 years old. He had bone marrow failure that was quite severe, and he had the mucocutaneous triad of skin, nails, and oral leukoplakia. He was in our first TNF2 study where we found the gene, and you can see his telomere lengths are incredibly short for his age. Over time, he underwent a bone marrow transplant for his bone marrow failure and did quite well. We showed that he actually had very mild cerebellar hypoplasia, which can be part of the phenotype. He developed significant gastrointestinal bleeding such that he had to have parenteral nutrition. And then he also developed a skin squamous cell carcinoma of his finger, shown here. After his GI bleeding was sort of under control, it was found that he was having shortness of breath and other problems kind of getting around, and he developed lung pulmonary arteriovenous malformations as well as some signs of fibrosis, and I'm going to touch on all that in a bit. And he also had liver disease, and unfortunately he passed away at 18 years of age due to these complications, which are really quite typical of our most severely affected patients. And there are some genotype-phenotype correlations as well. Now, the other end of the spectrum, there are patients who have later onset disease, meaning not maybe till like middle age or even older, and they may have isolated disease, pulmonary fibrosis only, aplastic anemia, liver fibrosis, even head and neck squamous cell cancer, and they may not have all the features of DC. Sometimes the family history is helpful, sometimes it's not. These patients are more likely to be heterozygous, and an added challenge is that in our families with DC, we see genetic anticipation where, in this example, the proband who we met at age 12 had disease onset and classic features at age 12, and you can see his maternal grandmother had no symptoms even up to 70, and his mom was sort of in between. So this adds to the complexities of diagnosis. The other types of disorders that are part of this DC telomere biology disorder spectrum are Hoyle-Riederson syndrome, which has features of DC in addition to cerebellar hypoplasia, intrauterine growth retardation, and immunodeficiency. Revesz syndrome has some of these same features, but is really defined by bilateral exudative retinopathy. And Coates Plus, which joined the DC telomere biology disorder family when germline mutations in CTC1, which is a telomere capping gene, were found in the recessive form of this disorder. So one of the early things that we did in looking at clinical and epidemiology approaches is we looked at, in our study, you can see here on the left is in 2009 with 52 patients, and in 2017 we had 197 patients with DC in our cohort. And what you really see here is that the cumulative incidence of needing a bone marrow transplant or dying is about 40% by age 40 years. And it's sort of this steady, slow increase in rate of bone marrow failure. And then also, though these patients have an increased risk of solid tumors, that usually isn't until till adulthood, although there are cases that are different. When we looked more specifically at cancer in patients with DC, we found that we looked before, which is shown in blue, or after bone marrow transplant. And what you see is, I think what you may expect is that after bone marrow transplant, the risk of cancer in patients with DC goes up considerably. And the most common cancers in both, whether they're non-transplanted or transplanted, are head and neck cancers, including mostly of the tongue and oropharynx, as well as AML, MDS, and some lymphomas. So in addition to the complications I showed you of our patient, is we really need to be screening these patients for cancer early on. So the topic in the session that we're in today is pulmonary disease. And so I've really changed my talk up to talk about pulmonary disease in DC, with the caveat that I'm not a pulmonologist, but we've done a lot of studies in collaboration with them. And I just want to put this slide up here as background for anyone who's interested in looking more at pulmonary fibrosis and telomeres in the adult. Most of these are in adult populations, including treatment trials and correlations with telomere length and outcomes. I'm not going to talk about this, but I am going to talk about our experience with our own clinical cohort of patients. So this was one very typical patient. If you had been reading the pulmonary fibrosis literature, say 10, 15 years ago, you might see someone like this who presented with thrombocytopenia in her 30s and progressed to pancytopenia. She was able to be maintained on oral androgens for her bone marrow failure for more than 20 years. Her mutation was identified in her late 40s, and she's a heterozygous TERT mutation patient. And her mom had pulmonary fibrosis in her 60s. And unfortunately, our patient here, as you can see, developed progressive pulmonary fibrosis and passed away at the age of 58 due to pulmonary fibrosis. Here's another case, and this was really one of the first cases that I saw with DC and his progression as well. It's a different patient than the one I showed you earlier, but a 4-year-old male who had severe aplastic anemia underwent a successful bone marrow transplant. Was doing really well. Looking back, his family noted he did have dysplastic nails and skin pigmentation abnormalities early on. He developed pulmonary symptoms with shortness of breath around age 11. We found his gene, TNF2, around the same time, and he underwent a bilateral lung transplant at age 13. And at the time, this was his chest CT prior to transplant, and you can see he has diffuse fibrosis and bronchiolitis obliterans in the explanted lung. So this, at the time, prompted Neelam, Gary, and I to do a literature review and report this case. And what we found was that, based on the literature, is that the patients with DC who had undergone a bone marrow transplant, shown here in red, had pulmonary disease much earlier onset than those who did not have a bone marrow transplant. Which, again, there's a caveat because this is a literature review, and it's also complicated because it's the more severe patients who are more likely to need a bone marrow transplant. So as our cohort grew, we were able to prospectively study the baseline, to look at the baseline PFTs, the pulmonary function tests and outcomes in our patients who we saw at the NIH Clinical Center. So we had 113 patients who we did pulmonary function tests at the NIH Clinical Center, and then we followed them to see what happened over time. And of this, you can see 43 had no transplant. 67, we also studied unaffected relatives. So this was really key in that we had some relatives who were carriers of genes of the mutation that their child was biallelic for. And then we also had mutation negative parents and siblings in the study as a control group. And what Neelam found in looking at this was that for our patients who had pulmonary function abnormalities at baseline, they progressed relatively rapidly to more severe pulmonary disease. And those, of course, who had pulmonary function that was normal at baseline were doing better. Again, it's a little challenging, but because we're looking at cumulative incidence and we're not able to follow the subtle changes in PFTs over time. But what we really show is that understanding what the baseline pulmonary function is really key to making the next steps to studying the outcomes and even potentially therapies moving forward. So when Neelam also looked at the type at which gene was mutated, so we tend to group our autosomal recessive and X-linked recessive patients with our de novo TNF2 patients. There are no biallelic TNF2 patients reported in the literature. Clinically, they act very much like the recessive diseases. And then we compared that to the autosomal dominant. So these are the heterozygous TERT, TERC, RTL1s, PARNs. And we found really that when you looked at competing adverse events, the cumulative incidence, of course, of needing a bone marrow transplant was about 50% by age 30, and pulmonary disease developed later in these patients. But when you looked in the heterozygous patients, we showed that they didn't need bone marrow transplant as early, but their lung disease tended to develop later in life, as we might have expected. So another complication we see in patients who have DC or telomere biology disorders that's really only recently been described are pulmonary arteriovenous malformations. And I'm bringing this up because it's really important. There's sometimes a mixed picture in our patients, and because the symptoms overlap, including shortness of breath, clubbing, cyanosis, etc. And when we looked in the literature, there were case reports and one small series of patients shown at the bottom in 2015, where pulmonary arteriovenous malformations were part of the clinical phenotype. So as I was talking with colleagues, and we had developed the Clinical Care Consortium for Telomere-Associated Ailments, CCCTAA. And in so doing, we really wanted to bring an international group of people together to share cases, to build these case series so that we can continue to define the phenotypes, because really in DC, we're still at this point of defining phenotypes as we're starting to also think about how to treat patients. So with our collaborators, Payal Kincha and my group combined all of the data, and we had 13 patients who had pulmonary arteriovenous malformations. And we see that most of them, almost half, had TNF2 disease. Most of them also, or they had recessive disease. And what was really remarkable was 9 of the 10 developed their AVMs after bone marrow transplant, and 12 of the 13 had microscopic pulmonary AVMs, meaning that we really don't have great therapeutic options. People have tried various things like propranolol, but those are medications that haven't been studied in DC, and clearly an area that we need to start thinking about more. Along the lines with the arteriovenous malformations in the lungs, as I pointed out in that case study, gastrointestinal bleeding due to telangiectasias is becoming a major problem in our patients, really, because they're doing a lot better after bone marrow transplant now. And so in collaboration with the CCCTAA, we've also assembled a series of 16 patients who had GI bleeding. And Ryan Himes has submitted the paper that really is looking at the phenotype. How are people diagnosing? How are they treating them? What's the outcome of these patients? And so I'm hopeful that we'll have more information on all of this soon. As we put the PABM paper together, we decided to have a meeting of the consortium and brought together vascular experts, as well as experts in vascular abnormalities in the eye, which we see in Revenge syndrome, the lungs, the GI tract, and put the telomere biology experts to really try to bring everyone together and understand these disorders more. And we're actively collaborating. We have a new collaboration agreement, and anyone who's interested in becoming part of the consortium, please reach out to me. I'd be happy to talk about it more. So coming back to treatment perspectives for patients with DC and telomere biology disorders, I've talked a lot about the bone marrow failure complications, and that's where we showed early on in 34 patients, the outcomes were quite poor, 50% probability of survival at 5 years. Now that's improved significantly in the more recent era, in that, especially with Sunit Agrawal, who's at Boston Children's Hospital, his protocol is fludarabine and alemtuzumab, and these patients are doing much, much better. He's got some that are many years out, and it's now in multi-institutional clinical trial, and I can connect you as well if you'd like to learn more about that in that study. Androgens is something that gets asked a lot, and it is, I will say, androgens for the bone marrow failure in patients with DC are effective, and they can often serve as a bridge to bone marrow transplant. And that bridge is sometimes needed because a patient maybe isn't ready to go to bone marrow transplant, they don't have a good donor, that sort of thing. And what we found in our study, now this was not a clinical trial, this was a descriptive study, and we found 11 of 16 patients had a hematologic response and were able to sustain it. But we did see that the combination of androgen and G-CSF led to a couple patients with splenic peliosis. The biggest complications we do see here are lipid profile abnormalities that should be followed, and they also need to be followed for liver adenomas. Now, there's a study that came out a couple years ago from Neil Young's group that was a study of danazol, an attenuated androgen for telomere biology disorders. And this study got a lot of attention because they showed that it looked like in a very short time, telomeres lengthened in people who were on danazol. Now, there are a couple of caveats here in that we don't always know if telomere lengthening may or may not be a good thing. Because if telomeres are longer and cells can continue to divide, if they are not maybe supposed to keep dividing because they're have mutations and other abnormalities, that may not be a good thing. They also had a suggestion in the supplement of this paper that pulmonary function improved with danazol treatment. Now, again, it's also small numbers and really hard to quantify what is pulmonary function improvement in the timeline of this study, which was just over 2 years. So this prompted us to also look at our data in androgen-treated patients and what happens if you look at telomere length by flow FISH. And because the prior study used quantitative PCR, which has some limitations with sensitivity and specificity. And what we found really was that there was no significant difference between our patients who were treated or not treated with androgens and the changes in their telomere length. As you can see here, they pretty much all decline regardless of whether patients were treated. And we looked more specifically by gene. Again, the numbers are small, but you can see that this vertical line is when the patient started androgen treatment, and you can see there's really nothing specific. So I think the question about androgens, whether it's danazol or another androgens, and telomere length and long-term outcomes for DC is really an unanswered question. And I just want to point out as well that the diagnosis and treatment guidelines for DC are available at the Team Telomere website. Team Telomere is one of the two that I know of patient advocacy groups. The other one is called DC Action in the UK. And we work together to publish these treatment guidelines that you can download from their website. And we're currently writing the next version of the guidelines. So I want to leave you as immunologists as well to think about many of these unanswered questions that we have in DC. There's a growing list of DC-associated phenotypes that I tried to touch on, spectrum of as well as genotype-phenotype correlations. We know very well that there are associations with mode of inheritance and outcomes. We also don't know really the extent to which bone marrow transplant alters the DC phenotype. And that's really because patients have only over the last 5 to 8 years been doing better. So are these other complications that I've been describing due to the natural history of the disease, which is really what I think, but they are also have to be modified to some degree by the bone marrow transplant. So when I think about the knowledge gaps and things we still have to ask in telomere biology disorders and pulmonary disease, really there's the role of cellular senescence. This is a big question across the entire telomere field and in these patients. Senescent cells aren't just sitting there not doing anything. They actually are quite pro-inflammatory. And the other things I brought up that we need to know more about is genotype-phenotype correlations, as well as patients who have say a TERT mutation who develop pulmonary fibrosis, what's their cancer incidence? Because as we start developing therapies there, we need to be following these patients for head and neck cancers, leukemias, MDS, et cetera. Pulmonary AVMs in patients with and without hepatopulmonary syndrome, which I didn't really touch on, but patients get liver disease. There's also the confounding factor that they can have hepatopulmonary syndrome plus fibrosis and AVMs. So we really need to understand the mechanisms and how to separate out those features. And then therapies. Are antifibrotics helpful? That's mentioned in a couple of those reviews I showed, where there have been only 1 or 2 studies, and they're looking at antifibrotics and telomere biology disorders for pulmonary fibrosis outcomes. So really the jury is still out on that. The role of androgens in pulmonary disease, we don't know. Patients are undergoing successful lung transplants, but again, that's not ideal. It would be really nice to have a medication therapy. And then lastly, I'll just end with bringing out questions about immunodeficiency in DC. So we see patients who present in infancy, much like this little girl who had biallelic RTL1 mutations. And she presented with failure to thrive and a really kind of difficult to diagnose immune deficiency in infancy. And there are many patients like this. Immune deficiency is part of the Hoyle-Riederson syndrome phenotype, but it's not well defined. So there is some work going on in this area, but I think we have a lot more to learn. And one of the things that I would really like to understand is if we look at telomere lengths in lymphocyte subsets in other immunodeficiency syndromes, is there an overlap? Because there are going to be patients who clinically overlap, and as well as if their telomere lengths overlap, we need to know that because we really need to be able to figure out which is the appropriate aberrant, which is the appropriate biology for that patient so that we can better treat them and manage their complications. And with that, I'll end and thank you very much for your attention and thank the most important people in our studies who are our patients and families. The consortium is really growing, and please reach out to me if you have any questions or would like to join in our collaborative efforts. Thank you very much.
John Hurst, it's my pleasure to co-chair the session, and on behalf of my co-chair Joris van Montfrans and three speakers, we welcome you to the Q&A. We have about 20 minutes for questions. Please do put your questions into the chat function. They're coming through to us, and we'll ask as many of those questions as we can. I'm really sorry if we don't get a chance to ask your particular question, but we'll do our best. And roughly, we're going to go in the order of the presentation. So, Tracy, I'd like to start with you, if I may. And one of the questions that came through on the chat was about the duration of the impact of virus infections in relation to this immune rheostat. Do we know much about how long that takes and how different that length of time might be between different people?
Thank you. That's a great question. We have managed to work out that the length of time it takes you to recover depends on the severity of the inflammation that you had in the first place. So you can almost titrate it down to a stage where if the inflammation is not very great, you almost recover straight away. But if it's really severe, you can have a prolonged problem, such as in chronic disease, for example. You will have changes for a lifetime, but it can take many months if you don't then have another inflammatory event to actually get the system back to where it is. And it's all down to the extent of the repair that you have to make in the lung.
Thank you. And I guess the second question that I saw in relation to that, and you teased us a little bit, you hinted at the idea that there might be therapeutic targets, indeed therapies in terms of resetting that rheostat. Could you tell us a little bit more about how you see that field developing over the next few years?
I think in inflammation, we've spent an awful long time understanding how inflammation starts and observing it, and we've been absolutely useless at working out how to turn it off. And turning it off is an active process. It's not a passive process. So I do look on sort of the consequences of fibrosis as a normal process that hasn't stopped rather than a pathogenic process. But it's all about repair, again, that your macrophages have receptors on them that recognize apoptotic cells and cell matrix proteins. And if you and while you're clearing those away, your macrophages are sort of turned off. You can actually manipulate them therapeutically and restore macrophage activity. So it's linked to repair.
Thank you. That's really interesting. Joris, what caught your eye?
Tracy, I have one question that I would like to ask you. So this rheostat principle is so interesting. Do you know if there's any way that we can measure this in an individual patient, either in vitro or by a set of genetic, a set of genes that are being evaluated? So is the rheostat actually, is there research going on to measure that in an individual patient?
There is, but you have to get at the cells within the tissue site. So you can't do it from peripheral blood because the cells get adapted when they go into the lungs itself. We are actually now putting filter papers up people's noses and sampling the back of their nasopharyngeal cavity for markers that are associated with macrophage activation or macrophage inhibition. Because activated macrophages secrete loads of things and they cleave loads of receptors. So we're trying to get sort of a quantifiable readout of the rheostat. You can take macrophages out of the lung and look at their level of responsiveness, but we're trying to go non-invasive if possible.
Yeah, thank you. Thank you so much. John, did any more questions for Tracy come in?
I didn't see anything else. We should probably have a go at asking Klaus some difficult questions too, I think.
Definitely. Klaus, one question for you that came in actually. If you do a bronchoalveolar lavage in a CVID patient versus an XLA patient, would you expect to see differences there?
Yeah, thank you for that question. Yes, I do obviously think, because as I mentioned, the B cells are obviously one of the features we're looking for in the bronchoalveolar lavage of the CVID patients, which would be missing from the lavage in XLA patients. But I think besides this obvious difference, I think as we see also in CVID, it's a mixed infiltrate. So we do see usually lymphocytic infiltrates, but it's often also an elevation of neutrophils. And as soon as we see neutrophils, we very often will find also infectious pathogens driving this. So I would expect in agammaglobulinemia patients much more neutrophil-driven BAL samples than I see in CVID. So I do think there's not only a difference in the cell counts, but I think it's also a difference in the underlying reason and pathology in both diseases. But it will be shown whether BAL reflects actually what happens in the tissues. I think that is a big question, which obviously would be nice to answer.
Yeah, and another question actually, Klaus, that came in on the additional investigations is, do you know if you can actually guide your treatment based on the results of a biopsy?
Yes. And I would be even more interested whether I can guide it on the results of the bronchoalveolar lavage, which would be less invasive and would be fantastic, but it's the same idea. So the answer is, I hope so. I think we are too early to judge. I think it is important again to say that the majority of lymphocytes in the lavage as well as in the tissue are usually T cells. So there's still many more T cells around, but there are substantial numbers of B cells. And I think the beauty of what has been shown in several, and I think Paul Maglione I mentioned, Jack Roots, including rituximab in this treatment, and then there are several studies giving rituximab only, even so that you take out only one partner in the system, it may actually change the whole biology there, which may be sufficient. So yes, I think, yes, I would look for the lymphocytes infiltrating, and hopefully we will have more evidence in the future to really firmly say that this will direct our treatment options.
Klaus, I'm going to ask you whether you think we should be thinking about CVID, ILD as one entity, or actually this is a collection of different things. And underlying my question is really one about genetic predisposition to CVID, ILD, and what we know about that.
Yeah, that is again also an excellent question. Obviously, I do think, and I think here again, Jack Roots deserves the honor clearly, and also Paul Maglione and several other groups, especially also Helen Chappell's group and Smita Patel in Oxford, who really try to drive the histology analysis of this disorder. And it's clear that it's heterogeneous, so we will have different patterns of pathology in there. And I think it indicates already that there might be different pathology and pathogenesis driving these disorders. So I think we will definitely expect that they will see differences. I think the most relevant probably is the one is which one is progressive going into fibrosis, and really where we need to be very aggressive in our treatment approach from the start with. Because we do see interstitial lung changes which are stable in some patients for a long time, needing very little treatment in these patients. And so, yes, They are heterogeneous. There will be genetic different backgrounds. I think the dyskeratosis talk and the fibrosis in there, I mean, obviously showed in a spectrum which is on the other end of the lymphocytic infiltrates we see. But I do think that we will see in our dysregulation disorders, which present like CVID, we do see differences and also in the aggressiveness of the lung disease. So PI3 kinase has a different lung disease than CTLA4 and LRBA in my eyes.
And then I guess the last question for the moment at least is to think about interstitial lung disease more widely, and management there has been transformed by an antifibrotic approach, things like nintedanib, pirfenidone. Do you think there's a role for that kind of approach within CVID ILD too?
Yeah. So in the patients we cover, for most of the patients, I did not look into that drawer of therapeutic options yet because the fibrotic part was very little, at least to my extent of knowledge and with the histologies we had available. However, there were a few patients who were clearly going down a fibrotic road, and I think that might be the group where these drugs might be actually having the role of being involved in the treatment of these patients, yes. But I think there's a majority of patients where I do not think of this treatment line in the first place.
Thank you, Klaus.
Welcome.
Klaus, one more question for you. Do we know, have we actually proven that influencing GL-ILD and CVID positively affects prognosis? Do we have this data, or are we treating symptoms and scans, but do we not know if it really influences the prognosis?
Yeah. You're the person who did the systematic review, so I'm sure you can answer this as well. So I think we didn't answer this really firmly at this time. We all think that we do that, and we all encourage our patients that we are doing that. And I'm still very positive about that we do it. But as I mentioned before, there's a very different range of prognosis associated with ILD patterns in CVID. And I think in the aggressive ones, there is where we are really required to change prognosis. And just from the few patients I can judge myself, I would say, yes, we did, but it's really early to really say that on a broad scale. Yes, so I think, yes, I'm quite convinced we will do, but we will need to have the prospective studies to really show this.
Thank you, Klaus. Thank you so much. So we will now continue with questions to Dr. Sharon Savage. One question actually that came in is how does transplant actually help a patient in the field of GI bleedings and pulmonary fibrosis when there is actually a problem here that is adherent to the tissue, when there is really a tissue component that we cannot cure, obviously. So that is the question. Sharon, could you answer on that?
Yeah, sure. So I want to emphasize that for patients like I described with DC and this multi-system disease, that bone marrow transplant fixes the bone marrow. And we've gotten much better at fixing the bone marrow using bone marrow transplant. And what I was getting to was that now that we're in effect, because patients are living longer, and we are either a combination of seeing more of the natural course of the disease, as well as potentially modifying it a bit by transplant, we're seeing these other manifestations, including pulmonary disease and GI bleeding in patients who prior to the last decade or two may not have lived long enough to have those complications because bone marrow failure would have been their major problem. So we can fix the bone marrow failure. We do have some patients who have also undergone lung transplants and or liver transplants after bone marrow transplant. And they're, of course, complicated, and limited in number, but they're starting to happen, and we're also starting to look at those outcomes prospectively.
Yeah, there are some clinical questions as well. Obviously, there's a broad spectrum of in the phenotype of DC and other telomere disorders. But to your knowledge, has IBD been seen as a part of DC, and have bronchiectasis been observed in this type of patients?
So those are really good questions. And exactly, so the phenotype is very broad. And as we've discovered more genes and developed telomere length testing as a help in the diagnosis, the phenotype has gotten even broader. So as far as I'm aware, there haven't been patients who have had a classic diagnosis of inflammatory bowel disease. However, there are a fair number of patients who have had non-specific enteropathies that have included failure to thrive in infancy or childhood, some who have even presented with weight loss and abdominal pain and that sort of thing, even as teenagers or young adults, who then were also found to be cytopenic and then got their diagnosis of DC. So there's still a whole lot we need to learn in that area from the GI tract perspective. And then in the bronchiectasis question, that's a good one in that to date, the majority of the cases have had a typical fibrotic pattern in their lung pulmonary fibrosis, with the exception, of course, being the patients who have pulmonary AVMs, whose CT scans may actually look fine. And then there's a combination of patients who have had a mixed picture of pulmonary fibrosis and PAVMs. Bronchiectasis, it hasn't been a classic piece of that picture yet.
Okay, thank you. So one more question about the transplant situation. Would you recommend measuring telomere length in all pre-transplanted patients, or would you recommend doing a sort of a test on how well they will withstand the chemotherapy for all patients that will undergo transplant, or just a specific subset of patients?
So that's a really good question, and where I think I'll answer it in the setting of what we don't know about telomere length and primary immune deficiencies, because since that's sort of the real focus of why we're here. And we know that there are patients with DC, a telomere biology disorder, who present with a very difficult to diagnose immune deficiency. We've had those patients, very, 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 very young children. What we don't know is if you took a general clinic of primary immune deficiency patients and you measured the telomere lengths in just anyone who came in with a PID diagnosis. We don't know the sensitivity or specificity for differentiating a non-telomere disorder from a different PID. We don't know that level of detail from the telomere length perspective. So I think until we have those studies and where we get a better sense of understanding what's the overlap and what's the distinction between telomere biology disorders and immune deficiency for other reasons, I don't think we can kind of say, let's do telomeres on everyone with a PID who is going to transplant. I think it's something that, should be considered. And as I think people are doing more and more panel genetic testing, that we're going to find more kind of cases that you wouldn't have expected. I'm sure that's already happening. I see it more from the cancer genetics side of testing, where cancer gene panels are finding, and marrow failure panels are finding genes in patients who you might not have expected that clinically. And I'm sure that is happening in the PID community. And as the telomere genes and other marrow failure genes are added and these panels get bigger, we're going to have more atypical patients. And that's where doing those larger studies to get a better idea of, again, the overlap is going to help us understand how to better transplant patients and follow up for their outcomes.
And one last question, I guess, and a practical one. You've highlighted some very exciting networks which you're using to address telomere biology disorders, and a couple of people have suggested, actually, how do they get in contact? Practically, how do they happen? Is there a website that you can perhaps direct people to? Yeah,
and so our study website is marrow failure, altogether, marrowfailure.cancer.gov. Or the other thing is I'm very easy to find online. If you Google Sharon Savage, you'll find me and my contact information at work. So feel free to reach out to me. And if I don't know, if I can't answer your question, I'll do my best to connect people.
That's brilliant. We're right up against the clock, so it's going to be a goodbye from me, and I'm going to hand over to Joris to close the session. Thanks.
Thank you, John. Well, I would like to thank all the speakers for 3 excellent stories. This has been a really wonderful discussion about PID in the lungs. I would thank all the listeners and all the ones that asked questions. Feel free to reach out to the presenters if you have any remaining questions, of course. And this is to be repeated if you ask me in the next ESID, definitely. Thank you all.
Thank you.